Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by your friends at Integrated Home Care Services. We would like to remind you that the Q&A feature is available, so feel free to send in your questions for our speakers throughout the discussion. And with that, I will turn it over to our moderator, who joins us from Sage Growth Partners, Dan Durazio.
Good morning and good afternoon, everyone. Thank you so much for joining us for our webinar, Healthier at Home, the role of a healthcare benefits manager in improving outcomes and member experience, presented by Integrated Home Care Services, IHCS. My name is Dan Durazio, CEO of Sage Growth Partners, and it's an honor today to have Kat and Paul here with us. In just a few minutes, I'll share a little bit about their background, but just some opening remarks to get us set here on the topic. Home is where increasingly people are headed in the healthcare industry. It's where patients want to be, it's where costs can be lowered, it's where outcomes can improve. We've done a survey recently and found that the increase in demand, 80% of the respondents said this is a permanent trend in home utilization. That being said, home care is difficult. It can be uncoordinated, fragmented, it can even be mismanaged. And so what we're here to talk about today is that movement to home with Paul and Kat. And we want to explore these topics. Yes, we want to go home, we want to stay there, but what does it really take to make that an effective site of care for so many? And so before we get started, my honor to introduce our panelists, Kat Gesh-Wilson, currently the Vice President of MA Medicare Advantage at Blue Cross Blue Shield of South Carolina, my home state. Go Kat. Kat's got a really strong government operation experience with over 26 years of experience in Medicare, D-SNP, Medicaid in 7 states, and commercial operations, including California. Kat, that's a big enough state by itself for many. New plan, bid, RFP development, and P&L turnaround. So a wealth of experience that Kat will bring today. Really honored also to have Paul Pino, co-founder and Chief Development and Analytics Officer at Integrated Home Care Services, IHCS, a home care benefits manager. Paul is responsible for a lot, including driving corporate and business development, spearheading all aspects of the company's actuarial, medical economics, reimbursement structuring, underwriting, data and analytics function. Paul has extensive experience in all facets of MA, managed Medicaid, and commercial HMO industries. So there we have it, great audience. I'm just gonna throw the first question out. I'm gonna throw it to you, Kat. Why the push home? It's almost an obvious answer, but it's complicated. Can you just share for the audience why you're thinking of that?
Sure. I think, well, home is really important. And the thing is, having a relationship with someone like Integrated Home Care Services is extremely important and valuable. And it's valuable because they can be the eyes and ears of the plan to understand what's going on in the home. So it's really beyond just the care at hand. There isn't anybody on the phone that doesn't understand the need for drug adherence, safety in the home, making sure they have adequate food. Is there electricity? Do they need access to additional services? That's the value of being a Medicare Advantage health plan, is really creating a safe, comfortable environment for the member, and also understanding the needs where they are. And I think having that relationship with someone like Paul and his team is absolutely essential to the success of a good health outcome for our members.
Paul, we know that CMS is projecting nearly 7% growth annually over the next 5 years. And this trend here in many markets across the country. What are some of the biggest trends you see with the home as we look in the next year or two ahead?
Yeah, so Dan, thanks so much for moderating this. We see a significant level in increases in demand, right? Across the board, we've seen reduction in other post-acute care capacity. So SNFs are really not able to take the amount of patients they historically have taken. So we're going to see more and more patients come into the home setting. But I'll tell you, for us, is that our utilization trends are up about 35% from utilization per thousand standpoint. And that's across our books of business. You think about managed Medicaid, significantly up, Medicare Advantage, and commercial HMO. So from our perspective, one of the key things and one of the key trends that we need to look at is not only reimbursement, but what's happening with the underlying member. Because we're seeing more and more of these folks that are going into the home setting rather than some sort of institutional based care facility. Our acuity levels up 13%. And we're seeing that our partners such as CAT, they're seeing their average lengths of stay increase significantly because there's not the level of availability out there to take these members into the home setting. So we do see that there is an increase, and we feel like most within the home care industry, some of reimbursement has not necessarily come up along with that increase.
It's really helpful. Paul, relative to that, fee-for-service value-based care, in the survey that we did, we find a lot of this care is still fee-for-service, not nearly as much in that value or that capitation arena. Can you describe your experience as you've been in many different markets and how that affects sort of the care at home and the mindset and the coordination?
Sure. So from our standpoint, one of the things that we realized early on is that if you're not aligned with the payer from an overall patient outcomes perspective and member satisfaction perspective, but really importantly from a cost or from a reimbursement standpoint, you're not going to be achieving the outcomes that are important for everyone, right? And so from our standpoint, to be aligned means to have the same goals in mind, not to create unnecessarily high utilization solely for the purpose of being reimbursed more money. For us, it's really about managing the patient, meeting medical necessity, and improving outcomes. So when we align ourselves financially with a payer, we're both really looking at what's best for the member and not necessarily always what's best for our pockets.
Yeah, that's really helpful.
I'd like to add just one comment to that. And I think the alignment is critical. So the fact that this is, in my case, a capitated arrangement truly means that we both have the same incentive, right? And that's centered around the member. And I think, it's really important because these types of services, home health, home infusion, DME, they're often just contracted in your network, instead of cultivating a relationship where the same goal is in mind. In this case, I hate to call you a vendor because I actually consider you a partner, because we do have the same goals in mind, ultimately the member.
We do, Dan. And I think one of the important things, Kat, and thank you so much for bringing that up. I think if you think beyond just the home care services that are offered, if you think a way that this partnership and that our partnerships are structured, and specifically around South Carolina, you'll find that we're delegated for utilization management, for claims payment and adjudication, and for really managing the network. And when you have that sort of infrastructure and you build out that sort of partnership, you really almost have no choice but to be aligned, right, Kat? I mean, it's really about matching not only our policies and procedures, but matching how it is that we're reimbursed relative to how you're reimbursed. And our successes are your successes and your successes are ours.
Yeah, the topic of home, like I said, I think you can read any white paper, Google anything, and you're going to find it. One of the findings in our survey was that 2/3 of the executives rarely discuss this on a regular basis. Kat, I know where the views have been traditionally about where the cost centers are. We often think about the acute space, right? Paul, in a little bit, I'll ask you to help us understand sort of that Venn diagram, home health, infusion, DME, and that connection. But Kat, why, maybe even in your walls or with your colleagues across the country, is this not discussed at the level that acute care services might be?
Well, I think it's oftentimes you focus on where the big dollars are, right? And you think, if I can just get my length of stay down without you actually have to take a step back and sort of peel the page back and say, what is driving those lengths of stay? What is driving where the care is being delivered? And that's exactly what happened here, is that, you know, if my length of stay is high and my utilization in the ER is high, that something's happening, especially for those individuals with 3 or more comorbidities, or they have an acute condition such as COPD. Well, if they don't have a relationship with somebody who's coming into the home, and it gets cold, and it does sometimes in the state of South Carolina, they're probably going to end up in the ER. That's not the best care for them. And so we have a tendency to view those other large buckets, but what's driving them to that type of care? And it's because they don't have a relationship for services in the home to keep them from that type of care. And by the way, that's not the best way to get care. And we know that, because it's very fragmented once they get to the ER. And then our ability to get them out of the hospital into the right setting is difficult. So from that perspective, it was an easy look to say, well, what's causing it to drive into those institutions the way that it is? And home health, home infusion, and DME were right there.
Mm-hmm.
Yeah, Dan, and if I can just jump on that 1 second. Look, from our standpoint, seeing patients within the home setting is critical, right, across the board. Sometimes one of the things that we find to be overlooked is some of just the basic needs that some of these patients have. If you think about socially where they are, there's some patients that aren't able to take care of themselves within the home setting. And so what will happen is you'll find that if there isn't a specific acute condition that's requiring staffing or some sort of equipment at any point in time, a patient wouldn't be able to convalesce. I think about, things such as attendant care and things such as long-term support services that include, bathing and facilitation with cooking. We find that the more we surround patients with the right type of services so that they can stay at home in a safe and dignified manner, we find that really helps turn the needle, not only on outcomes, but on reducing institutional-based costs. And quite frankly, just in the way that the member feels about not only their provider partner, but the plan that's sponsoring this provider.
Mm. I recently moved to South Carolina, Kat, so I'm getting familiar with the landscape. I came from Baltimore, where I could probably take a rock and hit 10 hospitals and all kinds of services. That might be true in many more urban or suburban areas. I think I've got the terminology right. We've got upstate, midstate, and the low country, right? I'm outside of Charleston. And I think about healthcare being incredibly local. And I don't even think about healthcare from a state perspective. I think about metropolitan statistical areas, and there's even sort of more micro landscapes in that area. So if we think about South Carolina, home is important on several levels, and help us understand that in relation to an ambulatory network, or an acute network, or the post-acute network, and how you're seeing that fit in.
Well, I think it's important to understand, once you get out of the major areas, such as maybe Greenville or Columbia, even Charleston, it's rural. And people's ability to access care, transportation is often an issue. And so our ability to meet the member where they are, even in a rural setting, is absolutely critical. Oftentimes what happens, especially in these rural settings, things will fester. I'm not feeling well, but I think I'll be all right. By having that connection in the home, they immediately know that member's not feeling well, and that they can take a course of action to make sure they're getting the care that they need. But in some areas, and I always say, sometimes there's more trees and rocks than people. And what Integrated really offers is they have very solid relationships with the home health agencies that are in those areas. And that to me is critical. They know who these people are, more so than I would, even just through a provider contract. So it's important that no matter where our members are in any of the counties that we serve, and we're in 27 counties, that they have access to care, just like somebody who's right in the middle of Columbia. To me, that is absolutely critical. And getting care quickly is really important.
Sure. And then part of that, Dan, is one of the real exciting things is the way that we communicate so well with South Carolina and with the team there. We readily share all the information that's required for them to truly become engaged with a member. If we're in a member's home and we find that there is some sort of issue surrounding any sort of social determinant, whether it be lack of food, lack of energy, lack of support, we will communicate that back to the plan so that the plan could ultimately intervene and offer the support that's available, offer the support that the plan has promised to the member, but the member may not have known that they had the ability to access this additional support. So really being the eyes and ears of the plan within the home setting is significant for us. And we're really proud of our ability to do that. And it takes a lot of investment. It takes a significant level of infrastructure from a technology standpoint, from a communication perspective. But ultimately, it's really about managing and understanding that experience between the provider and the patient. Mm-hmm. That relationship needs to be something that we continue to focus on and that we continue to really foster as we discuss and as we rate the providers that are in our network. For us, it's not just about giving a referral to any provider. For us, it's who's really making a difference. Who are we constantly seeing positive outcomes from? That is a significant difference between us and some other folks that are simply just managing a network. For us, it's really about what can this provider do to create additional value in a patient's life. And ultimately, that requires that they really know the patient's home well.
Paul, you've shared some data with me that was eye-opening about the connection between home health infusion and DME. And again, mm-hmm. we can look at these separately. In many markets they are, but I think there's a tremendous marriage often between some of these needs. Can you share a little data from your perspective from what you see?
Sure. So from a data perspective, what we find is that there's a significant overlap between someone who requires home health and someone who requires DME and someone who requires home infusion. That's why coordination is so important, Dan. And what we find in our historical utilization trends, and we see roughly, or we're responsible for 2.5 million lives that are contracted with us on an exclusive basis. We see that over 50% of home health recipients require some sort of DME. If you think about home infusion requires a professional nurse to be out there to infuse and handle the administration of that medication. So for us, the ability to truly focus on whole patient care and not just a fragmented approach is significant. In our experience, if the nurse gets there before the medication gets there, nothing can happen. The nurse is going to leave, and then the patient won't be seen for that day. If the hospital bed gets there after the nurse and the drug get there, where is the patient going to be infused comfortably so that they don't necessarily ultimately have to be moved mid-infusion or post-infusion, because sometimes there is the inability for a person to ambulate well. So from our standpoint, making sure that the patient is only speaking to one person who cares about them rather than multiple people who are descending upon them, it's significant. It's a significant difference. Our team makes sure that the DME company is there before the infusion medication gets there, before the nurse gets there. So that member can convalesce comfortably within the home setting and avoid a potential situation where that member has to go back to the facility to be treated.
Mm-hmm. I'd make a comment about DME. DME is easy to lose sight of, right? So it's a benefit. We approve the benefit. The product gets shipped and delivered, and we don't necessarily have a line of sight that they even opened the box. Okay. Right. So I think, or that they keep delivering it over and over and over again. So it's really important that when that box arrives, whatever it is, that member has an opportunity to understand the equipment. Maybe it needs a little help putting it together. Mm-hmm. Maybe they don't understand why they have it. And so I think that's a real solid example of how we function as a health plan to do an authorization. But what happens after that DME piece of equipment arrives at the house? Mm-hmm. And this is a surefire way to make sure that whatever that piece of equipment is or product is actually being utilized appropriately, which is critical for the member.
Sure, Kat. And if you don't mind me sharing, analytically, right, Dan, before we go into any relationship, we want to make sure that we're going to add the greatest amount of value that's possible. So we do a significant level of analysis. And when we analyze data, we're not just simply looking at cost structure. We're looking at provider behavior. We're looking at overall patient churn. We're looking at the manner in which providers are producing outcomes for not only the patient, but also for the plan. It's really important that the plan is able to see what's happening. We'll note that there is issues that really need to be addressed. And addressing those issues, what we'll.
Kat, is Paul going out a little bit on you? Yeah, we'll just give him a second. Might be.
While you're doing that, so
Can you hear me okay?
Yeah, we're good. We're good.
Oh, okay, yeah, I'm sorry. So from an analytical standpoint, really engaging and understanding provider behavior is significant, right? Because there's no two providers that are the same. In many instances, what we find is that some of the providers that are making the most noise out there about, changing reimbursement tend to be some of the highest priced providers that are available. So working with local community groups, working with people that really understand not only the folks that are in their community, but really understand the plan and what the plan's goals are important. So what we do is we come in and we make sure that local providers, regional providers have the same access to plan-based utilization and referrals than some of the larger nationals that have significant marketing teams that have really focused on just making sure that more referrals come to them and that more billing is available. We found across the board that there are significant opportunities to increase pricing for some of the local regional providers so that they can afford to staff additional cases, so they can afford to attract and retain additional talent. So from our standpoint, really partnering with the plan and reviewing the data really creates an opportunity for us to look at the market, look at the opportunity, and drive utilization to the right providers rather than just the largest providers.
Mm-hmm. Yeah, two interesting data points from the survey. 38% of leaders said they're only 38% say they're supporting their members well. And on the other hand, when we ask, how are they going to do this? 66% say they're going to manage it alone. A portion of them say they'd likely delegate some of that. And I think we had in one of our calls, I said, Kat, why are you looking at partnering? Home is so important. We're not talking about it as much. It has all these impacts. Why? Why choose this path? Because there's multiple paths to get to the house, right?
Well, I think it's really important that one, I find a partner to delegate to that has the same sentiment that we do about our members, right? This is beyond just doing home health and home care and home infusion. This is really about holistically understanding what is going on with our member. And we, when a member feels, and by the way, loneliness, we didn't even touch on this one. Loneliness is a very high issue right now with the elderly when they're at home. So forming a relationship with somebody who is a caregiver that they can trust is absolutely essential. And they're likely going to do quite well by forming that relationship. And they'll take their meds when they're supposed to take their meds. They'll get on the scales when they're supposed to weigh themselves. So I think for me, that's not something that we do. Maybe we're not experts at it. So finding a partner that really we could cultivate and really have some of the same approaches that we do around how we feel about South Carolina and those people that live in it, the state of South Carolina, really mattered to us.
Mm-hmm. Paul, there's a question that came in about ED, and Kat, I think you also have this hope that your patients are not going to wind up there when things fester. I think, Paul, the question was around low acuity patients, and even medium acuity patients. How are you preventing that movement to the ED, right? Which, Kat, to your point, everyone knows ED is expensive, maybe we're not always viewing it through the lens of home care, but we know that's a big driver. So Paul, in the work that you do, how do you prevent that, or how do you coordinate other services to make sure that's not where it goes? Because I've also seen data that even with the expansion in certain states with Medicaid, the ED still became a primary source of care access.
Sure. So can you hear me okay? Because I'm understanding I'm having some camera issues, so I want to apologize. There seems to be some computer glitches with my new setup. From a ED diversion standpoint, right? It's huge that we work alongside of our community-based partners. It's not just about post-acute care, right? It's about pre-acute care. And that has to do with our interactions with our physician partners and the specialists that are contracted with the plan. If you think about the appropriate type of relationship between a patient and a physician, there is that quarterback mentality that the physician needs to communicate with us in order to be able to tell us, look, there is this need, and then we will go ahead and we will work with our plan partner to make sure that that need is addressed. More times than not, the biggest issue and the biggest reason why someone's presenting into the ED stems from the fact that the resources are not available. There is a limited resource or a limited number of folks within a planned setting that truly have home care oriented expertise. For us, we can go into the network community, we can go wide and we can go large to make sure that someone sees that patient immediately. And that's one of the things that, Kat really focused on with us was our performance guarantees. Our SLAs in terms of, and SLA stand for service level agreements. Our service level agreements require that we staff something or a patient that has a need immediately.
Yeah, that's really helpful. Well, we've been using this term, the role of the home care benefits manager. Can you give us a little more perspective on what that means for you at IHCS?
Sure. So can you hear me okay?
Yes, we're good.
Yes. Care benefit manager standpoint, what we view ourselves as a partner that manages a benefit, very similar to what you see across the board from a PBM that manages the pharmacy-oriented benefit for a health plan. When you think about the role that we've delegated utilization management, network management, and claims, it's a vital role. Because what we do is we reduce the administrative burden that our plan partners have upon them. And in doing that, what we find is that the partnership becomes one of reliance on one another. We specifically get together, we regularly round, we work through any sort of challenges, and we come up with new and innovative ways to be able to service the members. So with Kat specifically and her team, we've developed not only patient opportunities around palliative, but we've also developed opportunities around personal care and other items that folks tend to, not necessarily focus on. The way that we manage a benefit, again, is not about reducing payments to providers. It's about selecting the appropriate provider to see a patient at any point in time. That provider is going to yield phenomenal results. And often that provider is not only building a relationship with the plan and with the patient, but also with us. And that affords us an opportunity to look deeper and really to educate one another on what's important and what we're seeing inside the home. But truly what it is, it's really becoming the plan's home care benefit administrator, for lack of a better term, when it comes to the manner in which they handle this benefit. What we try to do is we create a concierge environment for our provider partners where they have dedicated representatives that facilitate with any sort of reimbursement need, with any sort of lack of availability of resources. We truly work alongside of the market and the provider community to make sure that the needs of members are being met at every point in time.
Mm-hmm.
The only thing I would add is that there's other functional things as well. We talk about administrative burden, is that Integrated is very connected to the medical management staff that I have, whether that be social workers The STARS team, for example, there may be initiatives that we're focusing on, or we're concerned about what's going on in a particular area of our state. And we're able to communicate that with to our partner, and we're able to collaborate on an outcome. And Paul mentioned one, which is palliative care. Again, staying in the home, doing what we can to meet the member where they are.
Mhm. Paul, you're in dozens of states, very different geographically, culturally, even health-wise. And we asked this question earlier to Kat about the differences in geography in South Carolina.
Recording progress.
Back to the old school. You're good now. How do you accommodate for those local factors? Because what I hear you say is we're not just going out and creating a random network, right? I mean, this is on the ground, integrated. It's not like you don't have the challenges that other people have around the workforce and distance and time and place. So how do you get at that when you get dropped into new markets?
Sure. So the way that I apologize.
You're good now.
So the way that we handle that is really. So the way that we handle that really. So the way that we handle that really.
We've all been there. Don't worry about it. Silly technology.
Yeah, technology is wonderful. So the way that we handle it is truly by partnering alongside of the plan, looking at the historical teammates that they've had within the network, looking at what really matters to them, and then building strong relationships locally. Someone who tries to go in and manage an opportunity by throwing a slew of national, large network-oriented providers at a plan is never going to be successful. Someone who goes into an environment and attempts to really just force feed providers on how it is that they have historically done things, rather than truly understanding how providers need to operate to really meet the needs of their patients in those markets, is very different. As Kat had indicated, there's more rocks and trees in certain areas. I'll say that in certain areas that we service throughout the country, there's more cattle than there are people. And so from our standpoint, it's truly understanding what the plan values, what the patient requirements are, and ultimately how the provider can best be supported to render the type of care that's necessary. And really in doing that, and not just forcing our ways into a market on a rapid basis, but truly going at it slowly as we go through our delegation process with our plan partners, that is what creates a giant difference between us and someone who's just going into a market for the purposes of growth.
Mm-hmm. Yeah, Paul, I'm assuming some of this gets at the notion of convener, which I think has a different approach and is, one of the terms we use in the market is what you've described as that home care benefits manager really what's different from that pure convener mindset?
Sure. So, unfortunately, I think the term convener, by and large, has generated a negative connotation. People tend to look at it as a person that's going to come into a market and just dictate price. That's really not our goal. Our goal is to come into a market and really work on a behavior, and really work on an outcome, and really focus on our plan's needs. So if you think through the way that we approach a market, it's really about optimizing the provider's relationship with the patient, really optimizing the speed in which a patient has access to the appropriate services, so they don't have to go into the ER, so they don't have to be readmitted into a facility. And it's really about partnering with the plan. So if you think through the plan's restraints, the plan only has a certain amount of dollars to really focus on a team or a clinical team or another focus. When we partner alongside of the plan, what happens is now they only have one number to call in order to find a solution for something, rather than attempting to call around to find a provider that's willing to take a case at any point in time. So really that expertise in managing and in having a relationship with a plan where multiple services are delegated, That's a significant difference. And I truly think that as you think about the home care industry, there are some models out there where people are attempting to focus on what's best for the patient. But quite frankly, where you are right now within a convener methodology are folks that are just trying to go to the market and focus on price. And that's really what's defined a lot of what we're seeing out there. When you go to a market and focus on price, you're never going to be successful.
Mm-hmm. There's a question that comes up that folks have submitted about the family member and the caregiver. And I know in certain states in LTSS or MLTSS, we're obviously talking about maybe an MA relationship here, but the role of the family in that care, it's almost impossible to divorce the folks in the home who are incredibly important to this process. Kat and Paul, I'd ask you both how your organizations think about the family and the family caregivers and the members of that team.
It's a really important question. I give you an example of an elderly gentleman taking care of his elderly wife who has no ability to care for herself, and he's ill and needs surgery. And, being able to have that member call us and say, I don't know what to do. I need help. And in that case, we're right there. We're going to help them in any way we can. The types of relationships in the home can also be very complicated and get in the way of care. And I think that, having empathy for the situation for that member and, offering unique ways to make sure they're getting the care is absolutely critical. And I think by having that local presence and that relationship that's built over time creates trust, because there is a lot of mistrust in healthcare, especially when they're in the home or the individual, I'll just say a parent or a husband or a wife who is tired because they've been the primary caregiver. So Paul, I'll let you answer now. Sure. I know that you guys have a lot of passion around this.
We do have a lot of passion around it. So it starts from the way that we're reimbursed, quite frankly. Because we're not attempting to really, just throw volumes at a patient in order to be reimbursed more, we're really teaching and training when we get into the home setting. We're not only teaching and training the patient, but we're also teaching and training the family. We're in constant contact with the member. We're reaching out. We want to see how these folks are doing. But we never leave a patient's home with that patient or that caregiver wondering what it is that they can do to help. We're not simply waiting for a phone call so we can charge another visit to Kat and her team. And that's a significant difference. The other thing that we mentioned earlier is really some of the things that flow around the LTSS community. Although we're talking about Medicare Advantage, managed long-term services has historically afforded respite care. And respite care can, in essence, really, really relieve a home-based caregiver for a bit of time just to be able to get out of the home, just to be able to go out, take a deep breath. The care that they provide for their loved one as a result of being able to actually take care of themselves for a bit significantly improves the level of overall interaction between the patient and the caregiver, but also the manner in which they interact with us and the manner in which they're able to exist within the home setting as a team, rather than having someone come in and out of the home setting on a regular basis. So for us, the caregiver is significant. The caregiver really is someone that we focus and pay a lot of attention to.
Mm-hmm. Kat, we talked about member experience in the title of this webinar. We know that that's increasingly important for plans. What role or how far up the list does the home go relative to patient experience or other metrics that you care about internally, or that, quite frankly, are important for your financial sustainability?
So STARS is one of them, right? So there's an element of STARS, and with that is the CAP survey, right? So getting care when you need it is an example. Feel like you're getting good care. The members are going to say they're going to weight their experience based on the most recent, right? And if they had to wait 3 months to get a service done, they're probably not going to be happy about it. So we are a plan that does like to touch our members a lot. We reach out, we talk to them, we do, pre-cap surveys, just to make sure we understand where the member is. Because it's really important that when you introduce a service like this, that they have trust with their health plan, that they're going to get the right care at the right time. And having a contractual relationship with someone like Integrated really affords us that opportunity to continue to extend that relationship with a member. That we're not here just to process claims. We're here to cultivate a relationship and make sure that the member has what they need. That is critical. So STARS is a big one. There isn't anybody on this call that doesn't know the financial impact of STARS. It's important. It's important financially to the health plan, but it's really important for the member.
Really important, Kat, and that's a phenomenal segue into the patient, right? Because the more that the better the reimbursement is, the better the quality of the overall care is, the more that's afforded to that member, right? So when our plan partners go through their benefit design season and they're speaking with their actuaries and they're looking at what the opportunities are and designing these increases in benefits, there is such a great tie to what STARS looks like. From our perspective, not only STARS, because we do focus on client satisfaction or patient satisfaction, but also what we're doing alongside HEDIS, right? So if you think about the transition of care elements on the HEDIS side, if you think about the coordination around plan of all-cause readmission, where we're working alongside of our plan partner on medication reconciliation and other key components of what a member needs in order to convalesce safely within their home environment. All these things are things that we come together on. And quite frankly, there's nothing more exciting that when we're sitting down with a plan and we're coming up with a plan around how we're going to go out and how we're going to improve not only the notion of these members' care, but the care that they're actually receiving. And we're looking out for them. Much of this is proactive. It's not just reactive. Hey, there's an acute condition. Let's get out there. A lot of this is how can we best serve the members' needs? And rather than just focus on the relative value of home care, is how is home care impacting the greater component of care around these members, Kat? And I think those are things that we've often focused on when we're thinking through the member and the member experience.
So one thing I would say is you think about a relationship as contractual, and your willingness to take the same risk that I have.
Right.
And your willingness to do that because you can do it really well. And so whether that's STAR measures, whether that's cost, whether it's whatever the metric is, and the participation in the benefit build as it comes to the bid, making sure that the benefits are aligned with service that Integrated offers.
Yeah, I have a question related to this, and I can hear the frustration of the person asking this question, and I know you guys will be able to tackle it. Reimbursement, administration, and ops. Patients get the short end of the stick. How do you deal with this? I mean, Paul, we've had conversations around, look, stuff comes in and it might not always look perfect, and we're going to deal with it, right? I mean, this is the concern that people have, and it's a real concern. How do you get at the heart of that?
So, Kat, if you'd like, I'll go first, and then I'll hand it over to you, because Kat's going to check me on what I'm about to say. So, single point of contact is huge. A patient that comes into our care knows right up front what their benefits are. We discuss all of their benefits in real time. We're looking up all the information that's available. We're discussing ultimately what the items are and what the opportunities are that are going to be sent to the home setting. We're coordinating that freely. From a reimbursement standpoint, if we're talking about patient reimbursement, then we work with our patients to collect the member responsibility up front or collect the member responsibility somewhere on the back end. However it is that we're set up with a specific plan partner, but we don't use that as a boundary to care. Really, ultimately, what happens is a health plan would rather we figure out reimbursement than have a patient that's unable to convalesce within the home setting. because the expenses associated with an alternative site of care are going to be significantly greater than what we're talking about here. But really, when you think about the pain outside of the benefit plan, because the benefit plan in many instances is something that a patient understands. They have a copay, they have a deductible, they have a certain out-of-pocket maximum. When you think about the administration and the operations, that's seamless to the member. There is one point of contact, whether you're a parent that has a child that's in need of care, whether you're a child that has a parent that's in need of care, there's a seamless level of operation. I mean, we're talking a lot about Medicare Advantage again today, but when you think about the managed Medicaid book of business that we work, and we have, over a million lives, we have a significant level of children that require not only private duty nursing, which is around the clock shift work, but a significant level of therapeutic coordination of care. And so when you think about the manner in which all of this needs to be coordinated, not only for the child themselves, but you think about the parent who's working. You think about the parent who's attempting to create an environment with certain professionals where this parent is having to take this patient from specialist to specialist or from physician to some sort of facility. Really coordinating that alleviates a lot of the concerns that the patient has, because we meet them where they are. And so when you think about administration and operations, we really handle that well. And that's what stands out in the manner in which our patient care is viewed.
And so I think it's, even if it's not part of the capitated arrangement, it's part of fee-for-service arrangement, making sure that that's seamless. And that's one of the reasons why it was easy for me to delegate claims network in because it creates a more seamless environment. And, I think that evidenced by probably the delegation review that required for this, they learned that we do know operations really well, but so do they. And I think, that check and balance is critical, but that single point of contact and making sure we take the member out of the middle. Our number one goal here in South Carolina, take the member out of the middle.
I love that.
No member homework. Don't tell them they got to call somebody. My service representatives say, Paul, let me call the doctor while you're on the phone and let's get that scheduled. We focus.
Right.
Healthcare is hard. It's hard for people who work in it, right?
Right.
And so taking the member out and no member homework, and this relationship affords that additional opportunity to take the member out of it.
Exactly right. South Carolina is huge on quality. They're focused on first call resolution. They're focused on the overall member experience. Really, kudos to Kat and her team. They grew their MA population over open enrollment by over 20%. And so that only comes when you have the right type of benefits and the right type of member experience. Because ultimately, as you indicated, South Carolina is a very tough market, very competitive market. So to be growing in such a challenging environment is just something that really tells you that you're focusing on the right things for the member.
I think an important thing to remember is there's really only one differentiator in Medicare Advantage. Okay, we all offer benefits. We all have supplemental benefits. It comes down to one thing called service. That is truly the differentiation in the marketplace. And when you call us here, we sound like we're from South Carolina.
Except me.
I'm a Westerner too, so it's okay.
I joke with people that I don't need to be a futurist because we have so many problems in the past in healthcare that are still nagging us. And I would also call myself at best a presentist, meaning if I could just figure out how to make the present better, it would be great. But you guys are going to take us into the future, right? We've talked about the challenges and the coordination and the fragmentation, but lead us into the future. And even if that's a couple years down the road, 3, 4, 5 years, what are you excited about? What are we about to change that we haven't been able to get our hands around?
Pat, why don't you go ahead and go first? And then...
Yeah, I think one of the things is the access to care real time, whether that's in the home, whether it's in your neighborhood quite frankly. It's access real time and taking a holistic approach. We talk about supplemental benefits. We're not talking about just medicines and office visits here. We're talking about hearing, we're talking about dental or vision. Really holistically taking care of that member is absolutely essential, and having the right providers to do that is going to be critical. They have to, like I said, it has to be hassle-free. And that builds trust. And I feel like the consistent application of that is going to create member trust, and the member is going to have a much better outcome, because quite frankly, they control a lot. And CAP surveys is one of those. It's because it impacts stars, their ability to have access to care. So I believe that we have to do healthcare where the member is, which is local.
Yeah, so Kat said it best, right up front. She indicated it's not just about OTC benefits, and it's not just about who's giving more by way of a temporary phone calling card or something else. It's really about making sure that the patient can convalesce where they are in a high quality situation. I think that if you look at the way that healthcare is evolving, you're going to see that all type of reimbursement is going to be similar regardless of line of business. If you think about Medicare and you think about, Medicare Advantage, and you think about managed Medicaid and commercial HMO, there's going to be a lot more reimbursement around quality, not just about rate cell. And rate cells are important, and we understand why they're there. There's folks with conditions that require additional treatment and therefore require additional time and money spent. But ultimately, there's going to be a significant focus on the member experience, on outcomes, and that's going to impact reimbursement. So from our standpoint, one of the things that we've become extremely prepared for is a move to offer more and more services within the home setting rather than to peel them back. As someone had asked a question earlier about Medicare supplemental benefits and the way that those are flowing over, we've seen recently that folks are using Medicare supplemental abilities to have discharge planning opportunities within the home setting, which is not only the discharge planner working with a skilled provider within the home setting, but also affording long-term care within the home setting or the equivalent of it. If you have someone who's discharged from the hospital with a hip issue, is that person really going to be able to bathe and cook and clean? Why wouldn't someone offer them 4 hours of attendant care to have someone help them stay at home rather than have to be in a facility? And so when you think about supplemental benefits, it's not just about what these cards or OTC is, but it's really about what is it that we can offer a member that differentiates their ability to care for themselves or care or receive care in the home setting or have to be in an institution. And quite frankly, that's where some of the delta is, and that's where we see some of the change. We see that all of healthcare is going to be resembling its current broken parts into one communal way of looking at reimbursement and looking at patient care.
Mm-hmm. Yeah, we just have a few minutes left. We've got a bunch of questions that have come in. We've been trying to take them in rolling order, and Josh from IHCS will be reaching out to folks individually to cover other questions that we haven't been able to get to, Josh Holmes. But Kat, I think this is an important one. How do I convince my leadership to bump this up on the priority list if they're sitting in your shoes? We've talked about that, but there's only so many things that get priority, right? And the acute care might always win out, but what's one or two data points or talking points that you would share?
That's an easy one for me, because I got 50 plus initiatives going on here, but are we paying attention to it? So if we're not paying attention to it, then it's not being managed. Okay. The other thing I would say that's super important is I need partners in my world who are willing to go at risk just like I am. And I'm going to say this, it sounds a little cavalier, but if they're as good as they say they are, then they'll go at risk. And so it becomes a much easier story if I know that they're at risk as well as myself. And this is what they do all day, every day.
Yeah, that's really helpful. Paul, go ahead, Paul, please.
No, that's right. We'll meet management and we'll meet the team where they are. For plans that don't have a historical level of utilization that they're comfortable with, we can phase in to some sort of risk-based relationship by having other forms of reimbursement that still align our incentives, either some sort of reconciliation with a form of gain share so everybody's happy and everything's improving. But ultimately, it's exactly what Kat said. I mean, you need to put your money where your mouth is, right? And really, that's what we do, and we do that well when we see an opportunity where we can enact change.
Just a minute and a half left here, Kat and Paul. You've been incredible today sharing these insights. Just a closing thought, something, a fact that stood out or a moment that stood out in your career that's prepared us to go home, so to speak. And what would that piece of advice or insight or moment that you'd like to share with everyone so they remember this conversation and bring it forward to their organization? What sticks out to you?
Yeah.
I think what it really sticks out for me is, and it was blinding, right? So when you look at the data and you don't see it in the reports, but when you look at the data and you compare yourself nationally to utilization, especially in DME, I think you'll be surprised. And I would encourage everybody on the phone, if you haven't done that, you need to do it, because I was shocked.
That's awesome.
I think that's a great way of putting it. For us, it's about starting with the data. The data will suggest what it is that next steps should be. It's not just about looking to contract. It really is about a diligence process where we get to know each other the same way we got to know Kat and her team, and what your goals are and what your historical trends look like, so that we can design a program and really get your feedback in terms of whether or not this is something that your organization is comfortable with doing before you need to go and get all sorts of approvals. So for us, it's a living, breathing opportunity to partner with organizations. But before we break, because I see we have maybe 10 seconds left, Kat, on behalf of our organization, we just want to thank you so much for partnering with us, for the trust that you've placed with our team. And we certainly, look forward to continuing to deliver for you, your members, and South Carolina as a whole.
Yeah, Kat, thank you. Thank you to Health. Thank you to IHCS. Really appreciate everyone being here today. Let's go home. Take care.
Bye, everybody.
Bye, everybody.
Thank you to Dan and all of our speakers. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Nashville, March 26th through 29th for VIVE 2023.